We are turning our attention back to S-126. And we're still spending some time on sort of the concepts around section 2 and 3. And we have in with us today various people from AHS, and I'm going to start with Alicia Hooper from Kiva. Oh, and Sarah, are you?
Yeah, we're gonna sit together.
Tag team it.
Yeah.
Unless this is gonna be so hard that you might need. I hope not.
Yeah.
Meat hook.
Yeah.
See?
No. We are live.
Okay.
Yeah, I know, that's why I'm like not really responding, I'm containing myself.
Getting some time to get on the Zoom and
Yeah.
share screen.
Do you have a slideshow for us?
Yes, it's on.
All right, I'll pull it up myself.
I love that you're calling it a slideshow, like the old.
It makes it sound more interesting, right? Did they ever do that here? I don't know if anyone on the committee's been here that long.
What were the,
Alice.
I know where you're
She would
thinking,
know.
no, what was the film strips? Remember?
The microfiche?
And
No, don't fix
it was film strips.
beep.
It would beep and you'd turn it. And if you were really good in class, the teacher would like give you the, the honor of
And
flipping
then the
it.
overlay on the big
Oh,
screen.
yeah, I remember. Yeah,
That's.
Oh, yeah, where they put this, yeah.
Yeah, that's the overhead. Okay, let's, thank you. Mimeograph, back to the mimeograph. Remember smelling that?
I do.
Yeah.
It's like a roll that we get.
We've now moved on to PowerPoints, although I've heard that PowerPoint is no longer the term to use. What is it that we?
Oh, is it
What's the
politically
new
incorrect
deck?
now?
A deck? Yeah, I think it's a deck.
Correct.
It identifies
You're a
as a deck.
boomer if you call it
It's like calling your copy machine Xerox.
Yeah.
Well, soon it's gonna be directly projected into our brains if we don't do something about it, but.
Hey, thanks for joining us.
Thanks so much for having us this morning. For the record, I'm Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access.
I'm Sarah Rosenblum. I'm the Deputy Director of Healthcare Reform at the Agency for Human Services.
So we understood that the committee was interested in understanding a little bit about some of our current approaches to reimbursement in the Medicaid program and how we have been using reference-based pricing. And so we've got a few slides that we can walk through. So Vermont Medicaid has been benchmarking its Medicaid reimbursements against Medicare reimbursements for many of our services and for many of our providers for over 10 years. This has given us a consistent reference point in the form of those Medicare rates from which benchmark our rates over time. It has also given us the ability to ensure consistency in reimbursement across providers that are participating in the Vermont Medicaid network. So, with some exceptions, a provider in one community that is doing the same services is going to be paid the same as a provider in another community who's also doing those services. It's also given us the ability to incentivize certain types of services with relatively higher reimbursement. We can talk about some examples of that. And I think it's important to note that we've maintained this underlying structure of reference-based pricing for many different services while we have implemented some pretty broad-based payment reform for the Medicaid program. So we think of it as kind of the underlying architecture, and then we can build on top of that with innovative payment models or models that also incentivize outcomes and other quality performance. So I think this might be a fun slide. There's a lot of information on here, but we'll take some time to go through each of these lines because we do reference-based pricing in a lot of different areas for the Medicaid program. And just to sort of unpack what that means, we have different fee schedules that align with Medicare's reimbursement structures or fee schedules. This list here is all of the fee schedules that we reference-based price to something. And I'll say with pretty much entire consistency, with the exception of one line, Medicare is our reference point. For our dental services, we do not have Medicare as a reference point because they typically don't cover dental services. So we look at the Northeast Delta Dental Premier General Practice fee schedule as our point of reference. But just kind of going down the line so that you can get a sense of all the different fee schedules that we have. We have a fee schedule for ambulance services. The current payment methodology for Medicaid is to benchmark to 100% of the Medicare calendar year 23 rates, with a sort of single code exception that is 100% of the Medicare 24 rate. We have an anesthesia fee schedule that's at 94% of Medicare's rates. Clinical laboratory services are at 97.5% of Medicare's rates. Our dental services are at 75% of those Northeast Delta Dental calendar year 23 rates. The DME, or durable medical equipment, prosthetics, orthotics, and supplies fee schedule is currently at 87.5% of Medicare's rates. For our home health services, we have sort of two different benchmarks that we can look at, and I'm sure you've heard about this from some of your other witnesses as well. There's sort of a regular fee-for-service fee schedule that home health services have in Medicare, and we are at 100% of that fee schedule. But for the more comprehensive Medicare payment methodology for home health services, we're roughly at 67% of those reimbursements. For our hospital inpatient services, we also use a DRG-based reimbursement methodology. I know you heard a lot about DRGs in some of your testimony yesterday. We have a few places where we're not exactly the same as Medicare, and we'll talk about that on one of our next slides. For our hospital outpatient services, this is sort of an interesting category where we have different peer groups of hospitals, and the reimbursement rate for those different peer groups is different. And so by way of example, our in-state critical access hospitals receive 104.6% of Medicare's reimbursement, and our in-state academic medical center receives 80.5% of Medicare's rate. So we have a way of kind of adjusting our point of comparison with Medicare for different types of hospitals that are grouped together in these peer groups. Physician-administered drugs have their own fee schedule, and that is mapped to 98.5% of Medicare's rates. And then for our professional services, which I know we've spoken with this committee about in the past, we have two different points of comparison with Medicare. For primary care services, we pay 115% of Medicare's rates. And for all other services, we pay 89.5% of Medicare's rates. So there was a lot of information there. I can pause and take any questions that folks might have.
Mari.
Subacute rehab.
Rehab, that I believe falls in our inpatient.
So it's included in inpatient, even subacute rehab at a non-hospital related facility.
We might have to confirm that.
No big deal. It's okay.
Okay.
Thank you.
Leslie. I'm not really sure how to articulate this, but maybe you can help me. How does using this methodology support your program financially? Does it work, I guess is the question.
Well, that's for that question. I'm going to flip to the next slide because I think this is a really important thing for understanding Medicaid in particular. The percentages that we use are typically constrained by the available appropriations. I think in a perfect world, we would love to be at, at least 100% of Medicare for everything. Several years ago, pre-pandemic, we were at 100% or more of our fee schedules than we are today. But because we have not had corresponding increases in our Medicaid-based appropriation over that period of time, and because Medicare has increased their rates over time, our percentage has looked lower and lower. And I think that's a point of feedback that you've heard from some other witnesses as well. Having reference-based pricing can be helpful, but it's just a tool. And if you don't have the dollars to go along with it, sort of on our end of the spectrum where you might argue that our point of reference is too low, then it can mean that we're not using the reference-based pricing approach to infuse more funds into the system. And so I think that's a real challenge. There have been some benefits to having reference-based pricing for Medicaid, and we can talk a little bit about that. But I wanted to spend a little bit of time on some of the other considerations because I think they're helpful for understanding this general approach that we've taken.
Can I interrupt really quickly, just because, first of all, I'm printing off this last slide. I'm always trying to remember these numbers and I can't remember these numbers. It's not concerning this bill and for another time, but I'm curious if maybe you could go through some of these and if you would highlight ones that are you're statutorily required at that rate so that we can distinguish between ones that are set that way and ones that are set that way because we, the legislature, has said that is what it should be. Moving on to S-128.
Sure, we can certainly.
126.
That information.
I thought there was another one.
Yeah. So, you saw a long list of different fee schedules that we work with at Medicaid that are comparable to the Medicare versions of those methodologies. Some are relatively straightforward. Medicare will publish a code and an associated rate, and we can use that to come up with our code and rate at the percentage that we're sort of electing for a given performance year. Others are pretty complex. They have logic that kind of bundles certain types of codes together. If you sort of bill them in a certain order, the result might be different than if they're billed in a different order. The place of service comes into play when determining how much is paid. And so I think it's important to know that, like for the outpatient reimbursement methodology, for example, there's a lot of machinery that's kind of built into our claims processing system that enables us to use the Medicare approach as our foundation. But we had to do that foundational work. And I think it would be difficult for, anyone else that's thinking about reference-based pricing anew and trying to use this, and especially Medicare and their outpatient methodology, for instance, to approach it without having a deep understanding of all of those pieces and how they interact with one another. Medicaid, as I mentioned, has tried to maximize our alignment with those Medicare structures to the extent possible, but we've also made some choices over time to deviate from some of those Medicare structures where it has made sense, either for the context that we're in or for operational considerations, given our ability and the size of the population that we're serving. So a few examples here. We have chosen to customize by using those different hospital peer groups to determine levels of payment for different hospitals for the inpatient and outpatient services. And I think this is a little bit different from what you heard yesterday in the description of general Medicare hospital reimbursement, where they look at critical access hospitals and PPS hospitals. We have more groups, and we've been able to use those different groups to prioritize funding based on the policy priorities that the Medicaid program has had over time. And so that leads into go ahead.
I'm sorry, I didn't interrupt. What's a peer group? Is that like a DRG?
So let me go back to this slide for a second. So the peer groups, if you look in this section on outpatient services, we have a group of hospitals that are designated as in-state critical access hospitals. We have in-state acute care or PPS hospitals. We have a group that is in-state or out-of-state border academic medical centers, and that contains UVMMC and Dartmouth Hitchcock Medical Center. And then we have out-of-state border critical access hospitals, out-of-state border acute care hospitals. These are hospitals that are within sort of narrow geographic boundary of our borders because we recognize that a lot of our members are using those hospitals for services. And then we have categories for all other out-of-state hospitals. So we kind of group our different hospitals, whether they're in-state or out-of-state, into these groups of like entities. And you can see that we have different percentages for reimbursement for those different entities.
And there's a deliberate focus on in-state critical access hospital because there was a decision made that they needed that support.
So yes, so my next point was around critical access hospitals. So yesterday, I think when Boz was presenting, they gave an overview of the cost settlement process that Medicare uses for critical access hospitals. That is a relatively in-depth process that we did not feel historically, or probably currently, we had the capacity to carry out ourselves at Vermont Medicaid. And so what we chose to do instead of cost settling with critical access hospitals was to pay higher rates. So our rates reimbursement exceed 100% of the Medicare reimbursements in recognition of us not cost settling. So that's a place where we kind of simplified the process for ourselves and for our hospitals. They don't have to give us all of their information for cost settlement either. And we sort of recalibrated our reimbursement relative to other hospitals to try to meet the same policy objective that Medicare is trying to achieve by cost settling with those hospitals.
Can we just understand what cost settling is?
So in very simple terms, because I do not do cost settling, I generally what it is trying to acknowledge is that for different entities, they'll have different costs of care and costs of running a business. And so for most of our reference-based pricing methodologies, it takes into account general costs for general entities and tries to use that as the basis for coming up with a reimbursement. But it doesn't take into account like hospital A's actual costs of doing business. And so with cost settlement, what will happen is hospital A will provide information on their actual costs, and a payer will make sure that whatever they have been paid is kind of brought up to their actual costs with some sort of supplemental payment, or in the event they've been paid more than their actual costs, some sort of recoupment so that they are being settled to their costs. And so that is a way of acknowledging it could go up and down. We do have some reimbursement methodologies that are more cost-based, but those are not in the reference-based pricing universe, and they're typically for different types of facilities.
Thank you.
You're welcome. Another place where we've done a little bit of customizing is in our inpatient reimbursement methodology. We use the DRG payment structure like Medicare does, but we assign Vermont-specific DRG weights based on Vermont hospital costs. And I think this is important because it takes into account the different mix of services that a Medicaid population is using in a hospital setting versus a Medicare population. And a really good example of that is when we did our most recent inpatient hospital rebase, something like 20% of all of the DRGs that Medicaid had paid were for births. And you don't have those in a Medicare population. And so we have done sort of our own assignment of DRGs, and that's all I will say on that today, because it's sort of a separate conversation, and we could certainly go more in depth on that if it's an area of interest. And then a final point where we've customized is using those two different conversion factors in our professional fee schedule, whereas Medicare uses only one. We've been able to use the two so that we can have a differential payment for primary care that has allowed us to go kind of above and beyond 100% of Medicare's reimbursement. And so just to sort of wrap up some of our thoughts on reference-based pricing, we've seen it support other policy goals and payment changes. So even though we are typically constrained as the Medicaid program by the appropriations that we have, it's been helpful for enablers to support certain provider groups where we wanted to increase reimbursements. They're using that reference-based pricing structure and saying we're going to pick a higher percentage for this type of provider relative to other providers, as in the case of primary care versus other professional services, or for saying we're going to pay more than Medicare pays for critical access hospitals than we will for other hospital services. We've also found it really helpful to have this sort of decade-long history of reference-based pricing as the basis for our reimbursements when we have transitioned to different types of payment methodologies, like the fixed prospective payments for hospitals or for primary care practices through the ACO model, because it's given us more confidence about the inputs being consistent across provider organizations. When we're figuring out what a base payment should be for switching to a prospective payment, we know that, hospital A and hospital B were both paid using the same rules, and their bases aren't going to be wildly different because, one was maybe better able to negotiate higher payer rates than another. So it's given us kind of a confident foundation for moving into those alternative fixed payment arrangements. So I will stop there. Happy to take any other questions.
Any questions? I have two. Oh, Mari first. Go ahead.
So it sounds like in general, because of the success you've had in your application of reference-based pricing, that you would support, Adeva would support the bill that we're talking about.
I think Diva has seen that reference-based pricing has been helpful to us as a payer. We know what we know about other payers and how they operate. And so I think generally we are supportive of reference-based pricing. We think it's a helpful tool that our system could use, but acknowledge that, there are probably limitations that other payers may have that we don't know about.
Yeah. Thank you.
What do you did you have a question?
Yes, would anything change by implementing Bill 126 with the information that you've provided today?
I don't think anything would change specifically for Medicaid, because we would expect that we would continue to use these reference-based pricing approaches and that we would still be constrained by our appropriation and our ability to put additional funds into the system. I do think it could mean some pretty significant changes if other payers are using reference-based pricing, in particular commercial payers.
I'm curious, so for certain outpatient service, outpatient hospital, there's often a facility fee. And I know that Medicare does not pay facility fees. Does Medicaid pay facility fees?
For our well, I think I probably shouldn't speculate unless I have a good example to give you. So we don't specifically pay facility fees. There's the outpatient reimbursement methodology that, as I mentioned, takes a lot of different factors into account, including the things that are billed, the place of service, the providers that are rendering the services. But we are like Medicare generally, and so.
And my other question, or maybe not a question, but a clarification. We talk about, we've been talking a little bit about site neutral payments. I just want to so Vermont Medicaid pays for the same service. I'm looking at a list of hospitals because I have to remind myself which ones are which. So if I'm seen at North Country and I'm delivering a baby. Because you've got the enhanced DRGs that Medicare doesn't, because they don't pay for a lot of those. So if I'm at North Country, I'm going to get the exact same amount that, say, Gifford gets, because they're both critical access hospitals. You make no distinguishing between the peer groups. Or if I'm an obstetrician in St. Johnsbury, I'm going to get the exact same amount for a global delivery, uncomplicated or vaginal delivery as an obstetrician down in Bennington. same amount from Vermont Medicaid.
For the
For the,
professional
for the professional
components.
component.
Yes, the professional component, the same reimbursement would apply regardless of where you're doing the service. For the hospital component, it depends on the peer group. So critical access hospital A and B in the state will receive the same amount versus, a lesser amount being paid to the academic medical center for the same service.
And a provider who is employed by a hospital is getting the exact same amount for the same service as somebody who's not employed by a hospital. Or their services, the professional services.
That would depend on where the services are being rendered. So if the services are happening in a non-facility setting, like an office-based setting, that has a higher rate of reimbursement. If the services are happening in a facility setting, there's a lower rate of reimbursement, typically because it also is accompanied by an inpatient or outpatient claim.
Did you want to provide thoughts on H126 or S126? I know that you had submitted.
There's a little presentation or slideshow, should I say?
Yes, I believe we previously submitted comments or a memo and
see.
happy to come back and speak more as you get to other sections of the bill. But generally, I think AHS is supportive of the bill and the direction it's going. We've had a lot of fruitful conversations with GMCB and DFR and other named partners for the bill, and happy to come in and keep working with you on it as the weeks progress.
So this bill tasks the Green Mountain Care Board with coming up with the methodologies for reference-based pricing. Now, AHS already does this in our state Medicaid. Do you have thoughts on whether or not it should be housed within the agency or whether it should be stay with as it is in here with the board?
So our understanding is that the language of S126 speaks to commercial reference-based pricing, given that Vermont Medicaid already does reference-based pricing. And we want to keep it that way for DVHA to maintain their perspective on Medicaid reference-based pricing. That being said, I think we agree with the decision for GMCB to do reference-based pricing for commercial and just think throughout the bill, commercial hospital prices and GMCB maintaining that scope of practice makes sense to us.
And then there is this small number 5 at the end of page 3.
Yeah.
Wanted to get your thoughts on that since it does pertain to
Yep.
AHS.
Yep. And I believe a number of folks brought this up yesterday as well in testimony. Again, I think we understand, I think the intention of 5 is to speak to commercial. So I think some folks yesterday were like, why is this here? AHS already does reference-based pricing as exhibited by Alicia. So I think that's one thing, learning more about the intent of this section and what the real goal is, given that AHS already uses reference-based pricing, would be something we'd be curious to learn more about. And yeah, I think generally learning more about the goals of the intention for AHS to do this, I think would be helpful for us moving forward.
Any questions at all for either?
I
Yeah,
have
Woody.
another question. Are we planning on having the healthcare reform officer in to talk about 126?
Well, we have Sarah in here.
Well,
right?
But I guess just what type of role are you playing with or interacting with the Green Mountain Care Board in their reforms to our healthcare?
I'd say pretty significantly in current state activities. And then in the context of this bill as well, I think we've had several conversations with GMCB about our individual testimonies and the direction of the bill and roles and responsibilities. We've had for the last several months, I think, a very close working relationship with GMCB on kind of the current activities in Vermont's healthcare system and where we are and what action needs to be taken to reform it, as you're saying.
And Woody, for disclosure, so sections 9 of this bill all pertain to I keep having to remind myself what it is, the statewide healthcare delivery plan, which Agency of Human Services Office of Healthcare Reform, I would assume, would be kind of tasked with all of that. And I guarantee you, this is not the last time we will have AHS in.
True, on both counts.
Your schedules for the next month. So yeah, we'll hear from them a lot
Thank you, Chair.
because they're very important to lots of sections of this bill. Right now, 2 and 3 really mainly are having to do with the board. Any other questions? Okay, thank you. Thank you.
Thank you.
I'm sure we'll see you back.
Yes.
Thank you, thank you.
Susan, come on up.
Morning.
Morning.
Thank you for having me today. For the record, my name is Susan Ritson. I'm the Executive Director of Vermont Health First. We represent 215 or so independent clinicians who work at physician-owned practices across the state with primary care and specialty care. I don't have any slides. I did submit my notes this morning. I don't know if you have access to it, but so in general, we do support this bill, and we strongly support efforts to control hospital spending and implementing a fair and transparent pricing method, which, reference-based pricing could be. I know folks on Wednesday did talk about how there are different entities were paid, and if I may, I'd like to spend just a couple of minutes talking about that from the independent practice perspective. First, on the commercial side in particular, the professional fees paid to independent clinicians are often lower than that paid to hospital-employed physicians, and this is independent of any facility fees. Here's an example I got. It's a couple years old now, but basically, the professional fee paid to a hospital-employed cardiologist was 2.5 times more than that paid to an independent cardiologist. And this has a real impact because they're providing the same service. In this particular case, it was a coronary stent that happens at the hospital. So the physicians providing the same service at the same location, yet are paid less. And depending on, your who's on call that day, from the patient perspective, you could end up paying a whole lot more if the physician on call is a hospital employed physician. And so we've always been an advocate of equal pay for equal work. And the disparities don't make sense to us. And we think that reference-based pricing, if applied, not just to the hospitals, but more broadly, could help equalize that a bit. The other thing is payer reimbursement is the only source of fee for service revenue for independent practices. And, there are quality payments. I won't get into those, but strictly speaking, fee for service. You heard from the payer, there's a community fee schedule. It's basically take it or leave it for independents. They don't have the negotiating power. Health First isn't legally allowed to negotiate on behalf of our practices because of federal antitrust laws. So as costs go up, like, the healthcare premiums on the exchange, which most of our practices, that's certainly option for healthcare. They basically are looking at either reducing how much they're paid, or cutting staff, or, some of them basically try to see as many patients as possible, which is good for access, but there's only so many hours in a day. So it is a rate limiting step. Medicare rates, another issue. You heard Jessa talk about how those rates have essentially decreased every year since 2021. And if you consider the inflationary factor, which is not applied to the Medicare physician fee schedule, there's been a 33% decrease in payer reimbursement by Medicare. And this is impactful, not just from the Medicare perspective, but like Medicaid, many commercial payers peg their rates to Medicare. And so as Medicare goes down, so do the others. So it's a problem when you see the costs going up and the reimbursements essentially going down or not keeping pace. It's basically a recipe for insolvency, and it is definitely impacting our practices. And some of the other entities like hospitals and the FQHC has talked about other revenue sources like 340B programs. The FQHCs can get the 330 grants. There's encounter rates and graduate medical education payments. None of those are available to independent practices. So when you hear, the FQHCs and the hospitals are struggling at their current reimbursement rates, and independents don't even have access to those funds, imagine how difficult it is to keep these practices open. And we've lost a number over the years. And when those businesses go out of business, when those practices, patients have fewer options for care, access worsens, and then those folks are forced to get their care in higher cost settings, which is not something we want. Independent practices are disadvantaged in other impactful ways. They're not tax exempt, so they're paying more for supplies and things like that, property taxes. They have to get their insurance on the exchange, which, as we all know, is extremely expensive. And another huge barrier for independent practices, and not necessarily something this committee can impact, but it does have an impact, is the Federal Department of Education Loan Forgiveness Program. Independent practices aren't considered eligible employers. So you get somebody coming out of med school, they have a lot of debt, they might want to work at an independent practice, but they cannot just justify it if they can go work at the hospital and have their loans forgiven. It makes it really difficult. So moving on to the bill specifically, before I do that, any questions or about what I just said?
Not about I'm waiting till the end.
Okay.
I think I might be waiting till the end too.
Yeah.
Wendy, did you have any? Okay.
So the reference-based language in section 3 is certainly welcome. In my mind, it's not new, though. The Green Mountain Care Board has had rate-setting authority for some time now. And as you heard, Medicaid's been doing it for a while. To me, the timeline is too long. We've been talking about these issues for some time now. We need to take action. We're at the precipice. We have been for a while. Why wait? Let's do something. And so there's that. We also think that primary care needs to be, it would be great to have language in this bill to redirect resources to primary care, really shore that up. We all know that's needed. Same with mental health and home health. Let's do it. And because until we really redirect those resources, we're going to continue to struggle in the way that we are. I do in section 3, it wasn't really clear to me what the intent is. It seems like cost cutting is one intent, but the mention of site neutral payments sort of confused me. Are we looking to make it fair across all provider types, like independent and hospital employed, or have consistent pricing across hospitals? It just wasn't clear to me who would include. I mean, I think it's intended for hospitals only, but if the real goal is to, help support some of the non-hospital providers that are really high value, provide really high value services for the community. You know, site neutral payments or reference-based pricing that's applied to them and in sufficient amounts would be welcome. This is a small point, but one of, in the goals for reference-based pricing, you might add price transparency, because to me, that is one of the benefits of reference-based pricing. It's not this big black box. It's still complicated, but it can be a little bit more explainable. And, I was just wondering what sort of, and you don't necessarily have to outline this in the bill, it might be something for the Green Mountain Care Board to figure out, but what services would be subject to reference-based pricing? I think that's important. And thinking about those services that wouldn't be subject to it and how they might change as a result, and making sure that we aren't just squeezing the balloon so that the prices are inflated elsewhere. So those are my comments, and I do appreciate the opportunity and happy to take questions.
Brian and then Tupper?
So my question, were you observing, or I don't expect you to have done this, but were you observing the testimony when the Vermont Medical Society was here the other day?
Yes.
I asked about universal primary care, and there was concerns about it making things too complicated or not. What would be your organization's thoughts about moving to, because you talked about expanding capitated payments and fee for service. What are the benefits and risks of trying to move towards a system that guarantees primary care to everyone and fully funds the primary care system in a new way?
Yeah.
Whether that be like similar to all payer, like where everyone pays in and it's funded, or there's like a separate financing mechanism. Pros and cons.
Yeah. Great question. I mean, certainly we do have members in our organization who fully support universal primary care. Like most things, the devil's in the details, I think. But certainly I know it would be welcome from practices to not have to collect co-pays from their patients. I mean, if you think about it, that really affects the patient-provider relationship, for one thing. And as more people have high deductible plans, it just becomes more issue, and also affects the solvency of the practice. So I do think there could be some benefit. Jess's point, when you get too many different systems going, that can make it more complicated too. So it really depends on how it's rolled out and designed, I would say.
So would it be fair to say that anything we can do to simplify things, I'm going to be a little more specific, to simplify administrative burdens, including medical debt related stuff, cost sharing, et cetera, paperwork, and increase stable funding? In other words, like
Absolutely.
Yeah. Okay.
Absolutely.
Yeah.
That's what we need.
Yeah. All right.
Tupper, and then I see Leslie and Murray.
Thanks for coming in. You talked a lot about independent primary care physicians and the reimbursement and so on. And you said you would like to see something definitive in the bill. So I want to bring your attention to section 3. I don't know if you have the bill in front of you.
I have section 3 in front of me. And 2.
Page 8.
Number 5.
Okay.
Number 5.
I'm sorry.
Number 5, are you on?
For number 5, yep. Okay.
So, how could that be changed so that you would feel that what you've been asking for can be done?
I may want to get back to you on that, just so I can, give it some thought, but Yeah, I think just more globally, it's exactly what Brian said, stable, sufficient payments. I do think you might include both fee for service and capitated. That way, you have balances. Capitation, you're incentivized to have a big patient panel, but you don't necessarily have the bandwidth to see every patient in there. Whereas if you have some fee for service things in there, you're also encouraging clinicians to work to the top of their license. So you want to incentivize, but through fee for service, those things that you want folks to do more of, to keep, people out of the ED or what have you. So there's that. Are you looking for something more specific?
No, I was just
Mhm.
see how you felt about
Yeah.
that paragraph.
And then the capitation, because you want to be able to cover those things that the clinicians are doing to keep the patient well, whether that's calling them on the phone or care coordination with other providers or what have you. And to, have to fee for service those things is kind of cumbersome. So you want to have that capitation rate be high enough to cover those services. Because, primary care folks are doing a lot in the background that they're frankly not paid for, and should be. Because it's important work and developing that, having the time to develop that relationship with the patient, which is frankly one of the most important things in a primary care relationship. Without that, you just don't have the healing. So we need to pay the practices enough so they are able to develop that, have the time to develop that relationship.
Leslie?
So my question is maybe broader than just for you, Susan, but maybe you guys could weigh in. What I'm understanding is that we have a 10-year experiment of reference-based pricing that has been in our Medicaid program. That's a lot of information, a lot of experience statewide. How can that experience be used to spread to other payers and other parts of the system?
It's a great question. I think there is definitely a lot of knowledge and experience sharing that the Medicaid program could do with other payers or with the Green Mountain Care Board. And I think I would say again, our experience is very specific to working within the regulatory framework that we have as the Medicaid program, working with our claims processing system that is as old as I am. Like there are a lot of different considerations that I think might be payer specific to make it operational. I think conceptually, there's general agreement that this is a tool that could be used in more places and that it could get us where we want to be. I think that the challenge would be in understanding what those considerations are for all the other places where it would have to be replicated.
So is that conversation happening? I mean, I know you've been doing months, you've been talking about it. Is there a way for you to summarize it for us to understand your learning and how it might be spread or might not be spread? How does that in the reform world? Yeah.
Yeah, I would say the conversation is happening, although I think this legislation would aid in that effort and facilitate it. I also think this is somewhat adding on, but that section 5E or E5, whatever it's just reference, potentially that the intention of that language could be exactly what you're getting at, which is AHS has been doing reference-based pricing in Medicaid for decades. How could that learning be shared? I think GMCB is mentioned in that paragraph as well. So that could be in the paragraph that is speaking to information sharing and building on what the state already knows about reference-based pricing and trying to take the learnings from DEBA to other pay, whatever learnings there may or may not be that are transferable to other payers in the state.
I see you, Mari. Can I expand on Leslie's question really quickly? And Susan, I haven't forgotten. I got lots of questions for you. It brings up an interesting question. And I think, we might have been talking about this a little bit yesterday. Do you feel, I mean, this bill happens to be an example of Ford, AHS, DFR, all these. Do you feel as though that the current system of healthcare sort of oversight administration within the state of Vermont, do you feel as though maybe we have tasked you all with different things and now you have competing interests? And is there frustration with that? Or do we have to make a conscious effort to work together because we have set the system up where each party has a different task, which is at odds with each other?
Yeah. I would say, no, I think, you're right, that we all kind of have our own lanes and spaces and we, all do similar things, but for different payers, for commercial, for hospitals, for non-hospital. So I want to acknowledge, I think that's true, as far as current state, but I would say, at least given the context that Vermont is in right now, that we're already at the point where we all are very aware we need to collaborate together. Specifically because we operate in all those different separate spaces. I don't think it's led to frustration, potentially led to frustration among providers, but not among those of us in all those different groups.
Maybe inefficiency is the way I would put it.
Yeah, the other point I'll make is that I think this work is really hard and really complex, and Medicaid is a different beast from commercial, from, all from Medicare, et cetera. So, at the end of the day, I think whether or not we would have all designed this system today the way that it is, I think it has led to folks being able to specialize in certain spaces. And I would argue that we need that to a degree just because of how complex all these different areas of reform are.
Thank you. Back to.
Well, then take it to the next step is that, okay, I get the lane thing, that makes total sense. It's a complex system, but how do we overcome the lane? How do we start moving together? Does this bill do that? Is it important to do? I mean, I'm just trying to see how we move forward beyond our lanes.
Yeah, I would argue the bill does do that. And I think the conversations and testimony you've heard over the last couple of days, I think are continuing to move us in that direction.
Thank you. Sorry.
Hearing what you said about wanting to move forward faster than the timeline that this bill puts forward. I'll continue on as a question I've been asking a couple of other witnesses. In another piece of legislation, there was a proposal to start with the public employees, the VSEA plan and the educator plan. Would that be something that you would support? I know you'd want to start everybody sooner, but if we did it in steps, would that be something that we would support?
I would say yes. I mean, I know there's some concerns by some parties about doing that, but it moves us in the right direction and gets us adept at figuring it out on the commercial side. So yes, I would be supportive of that.
Thank you.
You mentioned providers having to collect cost sharing, and the cost sharing benefits getting I'm trying to not be judgmental, but it's hard not to say worse. In other words, like the burden of cost sharing for a patient is becoming greater. And then that means the provider has to chase after money or use debt collection or what have you.
Yeah.
How does that interaction around cost sharing impact the clinical relationship and how do you see it creating barrier to access to care for patients?
It's not something we've studied in depth, but I have heard comments from some of our providers that it is negatively influencing the patient-provider relationship. And yeah, and there's a lot more hostility in general toward providers. And we see this in the hospitals, but it's also happening in the community practices as well. And I don't know if that's related to just the cost of care and how difficult it is to access and everything.
And providers are patients too. So how do you see the rising cost of health insurance impacting the viability of doing business as an independent practitioner?
It's a huge concern. It's definitely affecting the solvency of our practices. I mean, the rates to insure the employees at an independent practice is astronomical and going up so fast. It's just a matter of time before it becomes too much and a practice will close. Yeah.
Are you hearing from providers as patients that they are foregoing their healthcare due to the cost sharing? Because they're facing the same thing the patients are. So as patients, are they making difficult decisions about getting medical care when they need it because of the barrier of cost sharing for them?
I don't know. I don't know the answer to that question.
So you know the premiums having an impact, but you don't know if the actual benefits are affecting you.
I know personally it affects it. I have a high deductible plan and it affects what I do. And, I don't have, at least, and I'm sure other Vermonters have a way harder time affording things than I do.
I appreciate that you won't speak for others when you don't know, but that you were willing to share the personal. So thank you.
Did anyone else have questions? So in the context of this bill and also kind of jumping off of a little bit of where Brian is going, I've had this revolving question in my head, which I know you all are making fun of me. What is a hospital? No, that was his question. You have compelling, and we've all seen over the years, that primary care, professional is less expensive outside of a hospital facility. Now, we can make the argument that that's because one of them is getting way too lower rates, commercially, but with Medicaid and Medicare, which pay site neutral. I've been thinking about,
Actually, that's not quite,
well,
but Medicare is definitely not site neutral, but
professional services for the equivalent type of site and facility and service. But how do we, it can't just be about money. What other things can we do to incentivize moving professional services outside of the hospital setting and more into a community setting? We just had the Northeastern reproductive services in here,
one of ours.
and they were talking about the wait times. That's not what the point of but we're talking about wait times, and there was a huge report that I remember we had to review a few years ago on wait times. What can we do to incentivize moving professional services outside of a hospital setting, which would help us with rates, cost containment, accessibility, other than just money? What does it take?
Lower health insurance costs for them, so, lower admin burden. Do something to levelize the loan forgiveness situation. I mean, some of it does boil down to money. It is hard to keep an independent practice solvent, but a lot of it is the playing field is uneven. So the practices are having to compete with much more better resourced entities, and it's just really difficult to pay staff at a competitive level when you're taking in less money. So doing health insurance, having a solution for that would be huge. That alone, you could give tax breaks. We don't get any of those. So there are things, more support in general, and just like operations, coding.
You had talked about, I was thinking about this in reference to, no, I can't think about it. I'm sorry, it totally lost my head. But yes, go ahead, and then I'll.
It'll come back the
Please,
minute someone
Wendy,
talks.
please.
There's one thing that I find that's always missing in these conversations is malpractice. Like, is that like a big barrier? And the reason I ask that is my own OBGYN have had to go to a facility, the hospital, because they could no longer afford because of that. Why are we never talking? Would that be an incentive to?
It would. I mean, we, as an organization, Health First is able to offer some discounted medical malpractice insurance for those who qualify. So that helps, but it's still definitely been going up every year. Went up a lot right after the pandemic. So it's definitely a barrier. Or just one more thing.
I remembered it.
Yeah.
Well, there's a minute I.
Usually takes me longer.
You had spoken about sort of a hybrid payment model of, maintaining a fee for service, and we're talking about primary care here. And then also a capitated payment. Capitation adds stability. It allows you to be paid for the services that you're providing that are non-reimbursable, care management, things like that. And this is mainly anecdotal, but also based upon a lot of the surveys, specifically that VMS has come in. My concern is, and this is also my concern with global hospital budgets and global anything and capitated anything, is it becomes so dependent on, we then want to measure it, and we spend all of our time working on quality measures or reporting. And we know that administration is actually what's driving providers out of independent, primary care, but also specialty care, because it's just easier to practice medicine if you're with a facility and they're doing it for you. So are there?
Or they go into direct practice.
Yeah, there's
Yeah.
there's that concierge.
Yep.
Direct practice. What suggestions can you or Health First make to us when we're thinking about these types of models and payment methods, that we also need to be thinking about how we ensure that we're not adding on more administrative burden or just more burden? And because I think we've learned that there are unintended consequences to everything we do. And I think we we really want to ensure that we're thinking about all those sorts of things. So I guess that's my directive is, can you be thinking about,
Any way to streamline, like just the payment streams that a primary care practice has coming in, it's really complicated. Like right now, they're trying to figure out the impact of this financial cliff that might be happening with, the all payer model ending. And it's really hard. So simplifying payment streams. One payment, sufficient payment would be great. We put all this onus on primary care for the quality, and I get it. We do want to measure quality to a certain extent, but primary care really isn't the problem. They're the solution. Let's measure the things that, there's, I don't know. I don't know the answer, but if we measure the things that we want to change, and incentivize those things that we want to change. You want the provider to see the patient on the weekend so they're not going to the ED when they don't have to. Incentivize that and measure it and add some incentives to it. But in general, yes, reducing the admin burden is huge. The admin burden with the payers alone is astronomical. I don't know a simple way to fix it, unfortunately.
Casey?
I'm just looking over your written testimony and appreciating the highlights that you made around the points that you ask us to consider. And I'm reminded of the deinstitutionalization of mental health and what we did with those services. And we just didn't fund them, right? We put those people out and gave them no place to land. And I'm just thinking, as we shift services or, try to be more cost effective, the importance of really, I'm struck by the importance of making sure that we give residents a place to land and how valuable it is to have specific recommendations and things to look at in terms of operational needs of these specialty care providers, including, I know you represent some mental health care facilities, don't you?
Not facilities, no. We do have full mental health providers in our network, but
Are the individual direct
Yeah.
providers?
yes. Yep.
We need those people. They're part of our system too. And so thank you for making sure that they are there to catch folks when they can't be part of the hospital system. I appreciate your points.
Thank you.
Any other questions? That's for Susan. Thank you.
Thank you. Important work.
We'll hear from you again. We're never saying goodbye to any of our witnesses. Pretty much we'll see everybody back as we move through other sections of the bill. I think we are all set for the time being. I'd like to be back here as soon as Jen is able to be back here. So we're waiting on Woody and Jen, and you anticipate, what time do you have to be?
11:30.
11:30, so.
Should be out before 12. I would
Yeah.
think.
Okay.
I would think.
Great. Thank you. We can go off a live.